So I'm going to talk about imaging of the circumflex coronary artery. These are my disclosures. I'm both a cardiologist and an intensivist. I'm not a surgeon. And I've got three areas that I'm going to look at, very specific take-home messages. I'm just going to revise very briefly the epidemiology of circumflex injury related to mitral valve surgery, very briefly revise circumflex anatomy with respect to mitral valve surgery, and finally, probably most importantly, remind you what you should be expecting from your echocardiographer at the head of the bed at the end of your operation. This was the first description of circumflex coronary artery injury during valve replacement in 1967. So we've known about it for a very long time. But when you look at the literature, not that many people have reported circumflex coronary artery injury for understandable reasons. This is a paper published, is this working? Yes, a paper published in 2010 looking at 12 or 13 either case reports or case series. There are some autopsy reports, but I rather suspect it's heavily underreported. In terms of our anatomy, we heard earlier in one of the previous sessions, the circumflex artery is close, in particular near P1 and the anterior commissure, and in about 60-65% of patients, the circumflex and or its branches may be actually between the coronary sinus and the mitral valve annulus. And if you look at the literature, there's some controversy as to whether certain groups of patients may be more or less susceptible than others. So if one looks at right dominant versus left dominant circulation, and in some very nice studies, they've taken the mitral annulus and divided it from one anterior commissure and 5 at the posterior medial commissure and 3 other marks in between, so 5 parts of the annulus. They've measured the distance from the circumflex and all its branches to the annulus. And this first paper, which is a very nice paper, showed that in a right dominant system, the circumflex was always more than 5 millimeters away from the annulus, whereas in left and codominant, it was variable. And these findings were supported by 2 subsequent studies, but then Pesser and his group came along in 2004 and said, actually, there's no difference in the risk between the 2 patient groups. Ender and group published in 2010, and they only published problems seen in a left dominant system and commented that in the literature there'd only been one report related to a right dominant system, and that was in a mitral valve replacement. There's much discussion about whether it relates to the proximity of the circumflex coronary artery or the size of the circumflex coronary artery, or both. And also one has to remember that in ventricular disease, the relationship between the circumflex and the mitral annulus is not static. As the ventricle remodels, it changes. So you're dealing with a difficult and dynamic system. So that's your epidemiology. What about how can you injure the circumflex? Well, you name it, somebody's done it. So you can tie a stitch around the artery, you can put a stitch through the artery, you can distort the circumflex artery, you can have a hematoma causing a problem, and then there are other causal mechanisms. The most common which we see is air due to coronary embolism. One other important consideration is when you're doing concomitant atrial fibrillation ablation, in particular radiofrequency ablation has been associated with circumflex injury. So that's the epidemiology and how you can damage the circumflex. What about how does your patient present? It may be very dramatic. It may be that the patient won't wean from cardiopulmonary bypass. They may have profound ventricular arrhythmias. More often, it's slightly subtle and may not be immediately obvious. You may see some ECG changes, hemodynamic instability, and or a low cardiac output state. And I just give this caveat, particularly if your patient has gone back to the ICU. Reliance on ST segment monitoring in critically ill is not very robust. So if you look in a general intensive care unit setting, up to about 20% of patients, despite ST segment monitoring, 12 segment monitoring, up to 21% of them have silent ischemia. So be careful of the patient that you send back to the ITU, and be aware that in the critically ill, we're supposed to use 12-lead ECG monitoring with echo and also with biomarkers, not ECG monitoring alone. So what about when we think we've got ischemia? Here's the ischemic cascade. Here are your ECG changes that happen relatively late. What about your wall motion abnormality? They occur relatively late in the ischemic cascade. So when you see an unhappy looking left ventricle like this, you very definitely have an injury, and this is not an early or subtle change. Other things you can do is look at other ways that the heart contracts. So if you look at the motion of the longitudinal fibers, which are endocardial, rather than your epicardial coronary arteries, they are exquisitely sensitive to ischemia. So here's normal longitudinal function, movement of the mitral annulus with normal transmitral filling. The patient becomes ischemic, so you have delayed and prolonged contraction. The left ventricle continues to generate tension for too long, and you have isolated airway filling. So these and tissue Doppler imaging are very, very sensitive and earlier indicators of ischemia. Now, of course, the gold standard is to image the circumflex, and when one thinks about imaging, one tends to think about coronary angiography and intravascular ultrasound. These are regarded as the gold standard. So this is a circumflex, or it should be a circumflex coronary artery of a patient who's undergone a minimal access mitral valve repair plus AF ablation, and the circumflex is no longer visible. The patient undergoes angioplasty as part of a sort of combined hybrid procedure, and then has IVUS, and you can see that there is a hematoma distorting and compressing this circumflex. So they then put a stent in with reperfusion, and the patient did extremely well. But I would urge you that you have somebody standing at the head of the bed that might be able to help you, and this is a very nice study looking prospectively at how one can image the circumflex coronary artery in patients undergoing mitral repair. So what they did was they modified a standard view, so they were looking at the circumflex artery from its origin all the way backwards behind the mitral valve, looking approximately prior to it crossing the coronary sinus and then more distally, and they were able to detect it in 99% of patients, the point of intersection with coronary sinus at 90%, and distal to this insertion at 86%. And they defined the echo views and the echo parameters you should do to get optimal imaging. They showed that after mitral valve repair, it can be more difficult, presumably because of the position of the annuloplasty ring. And in their study, they identified 3 patients with abnormal flow. The first one, it was pretty obvious something bad was happening. They had ST elevation, regional wall motion abnormality, and they demonstrated aliasing in the coronary, circumflex coronary artery, and the patient underwent reoperation on the table. Patient B had aliasing on the echo, indicating high velocity flow in the circumflex. This was flagged up to the critical care physicians. It was felt acceptable because there was no associated wall motion abnormality. The patient was discharged to the ICU, but 6 hours later became hemodynamically unstable, and so went to the cath lab, where the circumflex was successfully stented. And the third patient repeatedly failed to wean from cardiopulmonary bypass with a minor degree of dyskinesia and a minor degree of ST elevation. This is their coronary angiogram. You can see its circumflex here with a large obtuse marginal. Here is the bifurcation with the LAD and the circumflex, which they're demonstrating, and you can see the circumflex and the OM1. And what they demonstrated was that there was no flow in the circumflex, and there was aliasing or high velocity flow both in the obtuse marginal and the LAD. And they felt that they probably put too large an annuloplasty ring in that had distorted the coronary system, and they went back, put a smaller ring in, repositioned sutures, and the patient separated from bypass with no abnormal event subsequently. So the 3 things I've been through quickly looked at the epidemiology of circumflex injury related to mitral valve surgery, revised briefly the circumflex anatomy to try and think about which patients may or may not be more at risk, and know what your echocardiographer can do. They're at the head of the bed, and they should include circumflex interrogation as a routine part of any post-mitral study. Okay, thank you.